Again. Welcome everyone to Endo Community Conversations, a series of Q&A with endo experts and advocates hosted by the Endometriosis Foundation of America and My Endometriosis Team. I'm Marie Freeberg with My Endometriosis Team, the social network for over 120,000 people living with endometriosis. Tune in here at 4 p.m. Pacific, 7 p.m. Eastern, each Monday in March to dive in with us as we discuss the big important topics in endometriosis. Today we'll be focusing on fertility and endometriosis. I'm so thrilled to be joined by Dr. Karli Goldstein, a board-certified minimally invasive gynecologic surgeon and endo patient herself. Thank you so much for joining us, Dr. Goldstein.
Thank you, Marie, for having me. It's much easier now to talk without all the other speakers in the background. It's a big pleasure for us to be here and for us to be kicking this off for Endo Awareness Month. So thank you.
Thank you, Dr. Goldstein. It's wonderful to talk with you today. Can you start by telling us a little bit about yourself?
Sure. I really received my diagnosis of endometriosis I was maybe 29. I was actually a resident in OBGYN by that time. So I spent probably a lot of my teens and early 20s trying to figure out what was wrong with me, and had a lot of bowel symptoms and was diagnosed multiple times with irritable bowel disease or irritable bowel syndrome, things like that. And really, I didn't put everything together myself, actually, until I was a resident in OBGYN and interviewing a lot of patients with endometriosis for surgery before surgery, and realized that I had a lot of symptoms in common with them. And so this is unfortunately a disease that's not a huge focus in medical school, if we're all honest. It gets a little bit of a lecture in pathology and in some anatomy sections, but it doesn't really get what it deserves for being 1 in 10 diagnosis. And so really, my story sort of started in residency. At the time, I was trying to do egg freezing as well, and then sort of found out that I had early ovarian insufficiency, and really went through quite a fertility journey as well as surgical journey for years, and as a result of the diagnosis, but independently with the fertility world. So I had I can't even quite keep count of how many rounds of IVF I went through, multiple failed transfers. We had a gestational carrier for a bit. We lost the baby with our carrier. We had quite a road and ultimately achieved success, but it took multiple different trials and different doctors and opinions before we found out the right pathway to go. And it's important for me to say that there's not a perfect road for every patient necessarily, but I like for our patients and any patients I talk with to have at least options on the table and different opinions and support around them to hopefully achieve success in whatever sense that means for them.
Thank you for sharing your personal story of discovering endometriosis and dealing with fertility, and speaking how living through it with endo yourself has affected your work now as a surgeon. And our first question today was submitted by Dana on Facebook. And Dana wants to know, how does endo affect fertility? So why can some conceive and others can't?
So that's a great question. And endometriosis itself, it doesn't necessarily cause infertility, meaning it's not that if you have endometriosis, you're definitely going to have infertility and you're not going to be able to get pregnant, right? It's not a one for all, right? But it certainly is one of the biggest reasons that patients may experience infertility. So, and it sounds a little bit, funny to say it that way, but basically up to 50% of patients with unexplained infertility, meaning it's not polycystic ovarian syndrome, it's not their fallopian tube's not working necessarily, then those patients, out of 50% of them, they will have endometriosis. And we know that endometriosis causes subfertility, but I want to reassure everyone that there are plenty of endo patients that get pregnant, and they may even get pregnant easily, and things are okay. And so we don't have to have a doomsday look on it as soon as you get this diagnosis. Oh, I'm definitely going to have infertility and I'm doomed and I'm going to need IVF and this long road ahead of me. Okay. So there are many reasons it may cause infertility. So it's a loaded question to answer in a couple minutes, but I will show you one quick picture that I think is great. I'm going to keep it cartoon so that we're PC for all the viewers. 1 second. Okay. So this is a picture of a uterus from the side. This is a picture of the bladder and the bowels, the rectum. And what endometriosis looks like when we're looking inside, this is kind of like how we would see in an ultrasound or an MRI picture. But endometriosis can make deposits all over the pelvis outside the uterus. And you can see in this picture, it's made deposits in scar tissue, fibrosis between the uterus and the bowels. That can cause a lot of rectal pain, trouble with bowel function. And it's made some deposits here in front of the bladder. Now, this is a more advanced case of disease, but we're using it to illustrate a point that these deposits can basically go all over the abdominal cavity and in some cases elsewhere. This is sister disease of endoadenomyosis, which can create deposits within the uterine walls. And this can cause very painful cycles and also very much trouble getting pregnant, trouble with implantation, or maybe miscarriage. So any one of these spots where endo can go, it can distort the anatomy, meaning it could pull the fallopian tubes to the side, it could block the fallopian tubes, it could cause the ovaries to be stuck together, and it could cause cysts on the ovaries, which could affect egg quality. And even early stage disease, which may not do any of these things, the fallopian tubes may be normal, the ovaries may be in normal position, the bowels and uterus may not be cemented together like this. Even in disease like that, peritoneal disease, we do find that there is still maybe subfertility in those patients. And we think it's because this disease is an inflammatory disease, meaning there is a lot of inflammatory cells that will come to this area. There's a lot of scar tissue and inflammation around the lesions. And we think that this may be a reason why patients may experience a low level of fatigue because their immune system and their body is kind of constantly trying to fix something and trying to do something. And, in fertility, anything that's inflammatory, if you're having trouble with fertility, you really try to reduce and get rid of. But with endometriosis, if you don't get rid of these things, then it's very hard. It can be hard at times if there's multiple failures with fertility. If this environment is not really cleaned or reduced, then in some cases it may be harder to get pregnant, if that makes sense.
That does. And for those who are struggling with infertility, what support or resources are available for them?
Yes. 1 second, let me close this down. Okay. And I didn't mention, obviously, it can also affect egg quality. It can affect ovarian reserve. It could cause early ovarian compromise. It can cause trouble with the uterine shape, the endometrial cavity where the baby can grow. It can go into multiple different areas how it affects fertility. It's just hard to give a very short response to that. That could be a whole lecture on its own. So back to your next question, what resources do patients have? So, in the practice that I'm in with Suchkin Endometriosis Center, we do a lot of work with Endometriosis Foundation of America, and we have a lot of education sources on there. We're doing days like today. We did a day yesterday where we did, I hosted a day on infertility with endometriosis. And we're doing several things for March awareness, also a conference in the fall, probably in September, where we're trying to bring more awareness for patients, but also resources for them. There is Resolve.org, which is an organization that has a lot of resources for infertility on there, about all different types of fertility procedures, groups, meetups, links for social support for social workers and mental health when dealing with infertility, and resources on how to get medications for cheaper costs. There's all different resources now, which I think were not there 10 years ago, which is great to see. So, and of course, with fertility practices, many times, even though IVF can be expensive, there are places like New York that are making more mandates where there's universal coverage for fertility. Massachusetts has it. There's several states that are working towards it. And a lot of employers like Facebook and Amazon and Google and a lot of places that will offer fertility coverage right away for patients and employees of the company, which is great to see that really is changing. And I'm hearing of more and more places all the time that are doing that.
That is really good to hear. And thank you for listing the resources that are out there. Our next question comes from a participant of EndoFound's Patient Day conference, and they asked, is surgery for endo necessary before trying to get pregnant?
No, not at all. And, some patients may have surgery because they have a lot of pain and a lot of symptoms, and they may seek surgery first because they feel like they're not in a position or intercourse is very painful and, they're not able to try successfully. And so they move more towards surgery for the pain or for the painful intercourse or other reasons. But, some patients with endometriosis, many patients may get pregnant on their own with endo, and it may be okay. It may have no effect on the pregnancy. It can increase a few things in pregnancy. But again, that is not across the board. There are plenty of women with endometriosis that may go on to carry normal pregnancies. And actually, for a long time, you may have heard this from your mother's doctor or someone a long time ago, that people used to say, get pregnant, that'll cure your endometriosis, right? It doesn't. This is a misconception. It doesn't cure your endometriosis, but it certainly gives you, 9 to 12 months without a period, which is very nice. And then for women that are breastfeeding, it may give a longer period free. So maybe a year afterwards, 9 months to a year, depending on if you're doing exclusive breastfeeding. So the progesterone balance in pregnancy and breastfeeding can feel very nice for an endo patient, and also not having a period for that long can feel very nice. And so that's why I think that was a common thing to say for doctors. It wasn't that they were trying to be malicious or anything. It was just, or get rid of the patient. It was that they tended to see that patients would do better when they would be pregnant or breastfeeding. And I would say that progesterone balance is probably really the reason for that.
Thank you. That makes a lot of sense. I definitely had heard that and wasn't sure about the truth to it. So that's helpful to know. And then many other EndoFound conference attendees had a similar question. They asked, would you recommend that endo patients freeze their eggs? And if so, when should they undertake that process?
I think it's a fabulous question. And it's a great question, even for patients without endometriosis, or they're unsure if they have endo, right? It's a resource that we have now that has really been revolutionized in the last 10 years. And so I'm really excited about that. Even when I was a med student and a resident, and I was being told all these things, your uterus is retroverted, your ovarian count is terrible, you have the level of a 40-year-old, and all of these things that just set you into a panic and a frenzy, and didn't help me. The egg freezing technology still wasn't good then. 50% of eggs that were thawed actually died. They didn't make it further growth. Now, those statistics are close to 100% will thaw and make it, maybe 98% or so, depending on the quality. And so this rapid freezing technique, or vitrification, allows for a lot better quality on the eggs when they're thawed later. And if you already can fertilize them and you do have a partner or do have a plan, then the technology may be even better for thawing the embryos. And I think that I always tell patients, it's not something you 100% have to do. It's like an insurance policy, right? So it's, if your employer covers it, if your, especially if your job covers it, and it's something that's a big concern for you, but you have no plans to have a baby right away, and you're thinking maybe 10 years, or you're in a track like medicine where you're in school for 12 years and residency and all these things, I think it can be a nice thing to have a little bit more reassurance and something on the back burner. You may not ever use those eggs, but you may have them for later, so that if you need it, you have those eggs from when you were younger, and you may not need to use a donor egg from someone else or something if you're going through IVF, right? So, and when to freeze eggs, it's always better to freeze eggs earlier than later, meaning, unfortunately, the way ovaries are designed, or the way they work, is that we continue to release more eggs and every month and every year that we're alive, and the quality and the number of eggs actually diminishes quite significantly and quite rapidly. And so the quality and number of eggs will always be better when you're younger, meaning like in your 20s, or we're not going to egg freeze in teens or late teens. So really probably 20s is the best time, or less than 35. We know that there's an issue with egg quality, and certain conditions in pregnancy can heighten after age 35. So if it's possible, then you always want to do it on the earlier side. If it's not, any time is still okay. Most people will not freeze eggs after 40, 42. They would recommend at that point going straight to IVF and fertilizing them and seeing what you have, and not just banking eggs to use later at 50 or something, right? So earlier is usually better. Not everyone has to do it. And I think that, I jokingly say to patients, if you're, have a long career track ahead of you and you really want a baby, but you're not sure when it's going to happen, it's a good idea. If you're dating in New York, right? All jokes aside, but it's true. There can be many reasons. And with endometriosis, we know it's more higher chances of developing infertility later. So it can be great for you to freeze eggs if that's a strategy for you, and you're very certain that you really want a baby later and you want it to be genetically identical, to your, or not identical, obviously, but similar family genes and carrying forward.
Thank you. That's very helpful. Many users sent questions about pain management. So Dr. Goldstein, what are tips or recommendations that you would give to someone looking for help to manage the pain from endometriosis?
Yeah, it's a great question. It's a hard question. So typically at younger ages, like teens, we start helping with endometriosis by first working on the menstrual cycle. And if the pain is centered around the period, at the beginning of the period, or the first few days of the cycle, or with ovulation, then we may recommend things like anti-inflammatories alternating with Tylenol before those days are setting in. There's some medications that can work a little bit better, like Ponstel for uterine cramping, and they can be started the day before bleeding starts, or right with the same day that bleeding starts, and continued for 3 days to reduce cramping. I think that any of these medications with the anti-inflammatories and the Tylenol, it's important, obviously, if you're taking high doses of these anti-inflammatories, it can affect your stomach lining and cause sensitivity with your stomach. So it's important to take them with food. And of course, taking the right dosing and everything. I'm not going to get into it on here, but I think alternating those is great. I do work with patients on anti-inflammatory diet, low inflammatory diet, exercising when they feel good, not putting themselves through too much stress whenever they're actually in pain. And using things like heat can be very great for cramping pain, Epsom salt baths at night. Some people use castor oil packs, acupuncture, and then really reducing the pressure and the stress of digestion. So meaning whenever cramping is strongest, if digestion and bloating is a big problem for you, working towards those food sensitivities and low inflammatory diet, especially at that time, to hopefully have more bang for your buck and less cramping around those days, right? And I think that I do see this with a lot of patients around the holiday times. We have, Halloween, there's Thanksgiving, then there's a lot of holidays in December, January. Typically, patients will have more painful cycles January, February, coming off of all of that, right? And we're seeing a lot of incidents of heavier periods, more painful period, or at least heavier flow after COVID, COVID vaccines sometimes. And so I'm seeing kind of like a lot of uptick in symptoms like that. And so I think anytime those things are happening, it's good to try to get back to a lower inflammatory basis and work through it. We in our practice don't advise narcotic use. We see a lot of patients with trouble from it actually, and constipation, long-term side effects, pain, centralization, needing higher doses of anesthesia, a lot of very dangerous things that and interactions between medications, so we really don't recommend them. And we do find that patients may start on something small And then their doses, unfortunately, keep titrating up and up and up because it's not really working. So I would say that anti-inflammatories, Tylenol, even though people think that it doesn't work, actually can help when it's used as a staggered management for pain. And even anesthesiologists in the hospital do that while you're asleep, actually. They use Tylenol. 3 hours later, they use ketorolac or an anti-inflammatory, and they stagger things to give you multimodality coverage, we call it. So that's one thing. And then, acupuncture, hypnosis, there's, people do a lot of breathing work, yoga, there's a lot of things that can help reduce pain. Obviously, if pain is very severe and you're not getting any relief, you should see a doctor, of course, and talk about options. Many times birth control pills can be used temporary and sometimes long-term in order to reduce the severity of the periods, lessen bleeding, or stop the periods altogether temporarily in order to give the patient relief as well.
Thank you. That is so helpful advice to do right now on our own, and then also to talk through with our doctors. Thank you for all the great information today, Dr. Goldstein. Before we sign off, I wanted to ask one last question. As a member of the endo community yourself, is there any advice that you've received during your journey with endo that you'd like to share with the My Endometriosis team and the EndoFound communities?
I think it's great to have a support system around you that's understanding. I had, a lot of people during the fertility journey tell me one thing or another thing or give me all sorts of advice, but I really felt the best when someone was just listening and understanding, and I think that's very, very important to find the people that are most supportive and sort of give you what you need at that moment. So that may be just listening, or that may just be agreeing with you that this day is a bad day and let's just go for a walk and, take a breath. And I think that's really important. And there's actually a lot of, social groups now, social workers that can help with that. There's a lot of resources now that there didn't used to be. I mean, this disease is huge, that people are actually talking about it. And I think it's really great to see that patients really are connecting with other patients all over the place now, with organizations like this, and so hopefully it's going to be more on the map than what it is, has been in the past. And so I think that's very, very important.
Totally. Thank you. That's wonderful advice. Thank you so much for sharing your expertise with us today, Dr. Goldstein. And for those of you listening in, if you have a question that you want answered in an upcoming Q&A, leave a comment on Facebook or tweet us at My Endo Team. And if you're interested in continuing the conversation with others in the endo community, click the link in our bio or profile to join My Endometriosis Team, which is the official online network community of the Endometriosis Foundation. And don't forget to tune in this time next week for the next Q&A. I look forward to seeing you there.
Thanks so much, Maria. Great.